Okay, let me pull up the notes. Next, we're going to look at disorders of development. We're going to look at handout figure A-66 that I've uploaded on WC class. Some terminology that I want to cover with you that's actually, the prefix for it is actually quite appalling, but just so you're aware of where this terminology came from. Teratology is in reference to the study of monsters. And then what a teratogen is a stimuli or agent that disrupts normal development. And we'll actually take a look at a few of those teratogens. Okay. So here we're looking at disorders of development. We're going to first look at exposure to some disruptive factors for development. First one is our teratogens. One type of teratogen is radiation that can lead to disorders of development during the embryonic and also during the fetal period, exposure to that radiation. Also, thalidomide is a medication that was actually used in the 50s to 60s. It was used to treat morning sickness in pregnant women, that it would actually lead to malformation of the limbs in a developing human. Also, alcohol can lead to fetal alcohol syndrome. And what that leads to is in the growing human is growth, mental, and physical problems. There can be poor growth. Also, later in life, there can be problems with speech, thinking, movement, and social skills. Also, exposure to tobacco for the embryo and fetus can lead to eventually, early birth, premature birth, low birth weight, and premature birth can lead to later on learning disorders, behavioral problems, and low IQ. Okay. Also, maternal infections can lead to disorders of development and human development, such as syphilis and rubella infections. Okay, next we're going to look at some genetic disorders, chromosomal abnormalities such as Down syndrome, also Klinefelter syndrome, which can develop in males. Normally, males have an X and Y chromosome. However, in individuals with Klinefelter syndrome, they have an additional X chromosome. Okay, so that would be XXY. And in that case, there can be a variety of issues that arise, but one typical issue that arises due to that presence of an additional X chromosome is the development of female characteristics like development of breast tissue that you would typically see in a female. Okay. Also, another chromosomal abnormality is Turner syndrome. And that's where, and this develops in females, and instead of having two X chromosomes, there's only one copy of the X chromosome, or there can be both X chromosomes there. It's just one of the X chromosomes has a portion of it that is partially missing. Okay, so some gene disorders can relate to disorders with dominant genes, recessive genes, or X-linked genes. Okay, so some disorders of pregnancy that can lead to disorders of development in the human is ectopic pregnancy, and that is pregnancy that occurs outside of the uterus. Okay, the development of the conceptus outside of the uterus. Typically, you will see that in the fallopian tube. Okay, at that point, it becomes a medical emergency, and the female has to have the conceptus removed. But again, it can occur anywhere outside of the uterus, again, typically within the uterine tube, fallopian tube. Okay. Also, another pregnancy disorder are the development of tumors. One type of benign tumor is benign hereditariform mole, which is a molar pregnancy. That's basically a rare mass that forms inside the womb. Okay, eventually that benign tumor can become malignant choriocarcinoma. And with the malignant choriocarcinoma, that is a highly malignant tumor that arises from the trophoblastic cells that are located within the uterus. So typically, if molar pregnancy is not removed, it can develop, or that has a potential to develop into that malignant choriocarcinoma. So it's going to start off as a molar pregnancy. And about in 1/4 of women who've had a miscarriage or intentional abortion or a tubal pregnancy, that malignant choriocarcinoma can develop. Okay, so that would be in 1/4 of the women who have that malignant tumor. Another quarter can develop just after a normal pregnancy and delivery. Okay, then placenta previa is where the placenta is partially or totally covers the opening of the cervix. And in that case, when the cervix begins to dilate towards the end of pregnancy, the placenta, as the cervix dilates, can separate from the uterine wall. And at that point, depending on where the woman is at in her pregnancy, it can lead to bed rest. Okay, if it's preterm. Okay. Also, you have placental abruption, and that is where the placenta detaches from the uterus, and at that point, labor will need to be induced because there is no longer any oxygen, nutrients, waste products being taken away from the developing human. Okay. Also, there's toxemia of pregnancy. One is preeclampsia, which is high blood pressure of pregnancy. Really, it's thought to result from abnormal formation of blood vessels within the placenta. Okay. Eventually, preeclampsia can lead to eclampsia, and that is where seizures follow preeclampsia. So that is definitely a medical emergency. Also, delivery difficulties, forceps birth, and a breech birth. What a breech birth is where the buttocks or the feet come first. And at that point, if the physician or the nurse can't rotate the child within the uterus to force the head to come first, then a C-section may be required. Okay, so next we're going to look at monitoring of postnatal development. We are going to look at the APGAR rating. There's also a handout that goes along with that, which I'm going to pull out here. Okay, and the APGAR rating was developed by Virginia Apgar, who was an OB anesthesiologist. She developed this rating scale back in 1952. Okay, and APGAR is actually what we refer to as a backronym, which was a word that has been basically turned into an acronym. Okay, so the APGAR rating starts with appearance, and if you notice, it'll go through A, P, G, A, R. Okay, so appearance, which evaluates color of the newborn. Also evaluates pulse, the heart rate. The presence of grimacing, which should be present. So that evaluates response to stimuli. Also activity, which evaluates muscle tone of the newborn. And then respiration, which evaluates respiratory rate. Okay, so we're going to look at the scoring system for that. And the APGAR test is done right after birth. Okay. And so the newborn will be graded on a scale of 0 which would be poor for each of these characteristics, to 2, which is excellent. And then once all the criteria have been evaluated, the scores are totaled anywhere from a range of 0 to 10, with 10 being optimal. And this scoring system is really a good predictor of survival of the newborn, and then also the presence of any kind of neurological damage. Okay, so the total score of 3 is considered critically low, and at that point, medical intervention will need to take place. Score of 4 to 6 is fairly low. And then a score of 7 to 10 or 8 to 10 is considered generally normal. Okay, so we're going to go ahead and take a look at some of that criteria from your handout. Okay, so for the APGAR scoring system, the first sign would be, well, this one's not actually the first sign, but looking at heart rate, a score of 0 if the heart is not beating, score of 1 if it's slow, which would be less than 100 in a newborn, and then greater than 100 would be a score of 2. Okay, optimal score here. For respiratory effort, if respiration is absent, that would be a score of 0. If the respiration is slow or irregular, that would be a score of 1. And if there's good crying, then that would be a score of 2. Okay, so for muscle tone of the newborn, if the newborn is limp, that would be a score of 0. If there's some flexion of the extremities, which should be expected, flexion of the extremities you should see, would be a score of 1 if there's only some flexion. And then active motion is ideal, that would be a score of 2. For reflex irritability, and typically they evaluate this by using the suction bulb within the nose. If there's no response, that'd be a score of 0. If there's just a grimace, that'd be a score of 1. And if there's a cough or sneeze or crying, that would be a score of 2. Okay, then color of the newborn. If the newborn is blue or pale, that would be a score of 0. If the body is generally pink and however the extremities are blue, that would be a score of 1. And then completely pink would be a score of 2. I've also included another handout there on that if you want to take a look at that. Okay, so I have a video that we're going to watch on APGAR scoring.
For the APGAR, the newborn is given a score from 0 to 2 in each of 5 categories: heart rate, respiratory effort, muscle tone, reflex irritability, and skin color. The assessment is completed at 1 minute and repeated at 5 minutes following birth. The nurse auscultates the apical pulse to determine heart rate. If the rate is above 100 per minute, the infant receives a score of 2. If less than 100, a score of 1, and 0 if there is no heart rate. Respiratory effort is assessed by observing and auscultating the chest. A score of 2 is given if the infant is crying vigorously or if the respirations are spontaneous and regular, 1 if the effort is weak or irregular, and 0 if there is no effort. The muscle tone of a full-term infant is judged by the amount of flexion. Well-flexed extremities receive a score of 2. Some flexion, a score of 1, and if the infant is flaccid, the score is 0. The nurse evaluates reflex irritability by gently slapping the sole of the infant's foot or by inserting a catheter in the newborn's nose. A responding cry receives a score of 2. A grimace receives a score of 1, and no response is scored 0. Color is the 5th component, and the infant must be assessed for both central and peripheral cyanosis. If the Caucasian infant is completely pink, indicating oxygenated blood, the score is 2. The score is reduced to 1 if the hands and feet are bluish. If the infant is pale or if the body or face is blue, the score is 0. Because non-Caucasian infants may appear ashen gray, the mucous membranes of the lips, mouth, and tongue should be observed for central cyanosis. The scores for all 5 components are then totaled. A score of 8, 9, or 10 indicates satisfactory cardiopulmonary adaptation and requires no specific intervention. Scores between 5 and 7 indicate the need for stimulation and the administration of oxygen via bag and face mask. Resuscitation may be required if the score is below 4.
Okay. Okay, so next we're going to look at prenatal mortality. And the most critical time for development is at the beginning of pregnancy. We're going to take a look at the next page in your handout figure A-67. Okay, so as you can see, here we're looking at prenatal mortality and percentages here, gestational age and week, and I'll mention that here on the scale that we're looking at is 0 to 40 weeks instead of 0 to 38 weeks. Okay, so really in those first few weeks, up to about 8 weeks, there is a high chance of having a spontaneous abortion. Then it reaches kind of it kind of levels off at about 20 to 40 weeks. Okay, so definitely during the first few weeks, critically important on human development and survival. Okay, next we're going to look at spontaneous abortion. And here we're not talking about a medically induced abortion, we're talking about something that's spontaneous. If it occurs before 20 weeks, it's considered a miscarriage. If it occurs after 20 weeks, then it's considered a stillbirth, okay? So oftentimes after 20 weeks, if that occurs, it can also be referred to as fetal demise or premature delivery, depending on what stage of development that we're looking at. Okay, so abortion is a premature stoppage of development, and that would be before viability. Or it can be the premature expulsion of a conceptus, embryo, or fetus, and that would be before viability. So what I mean by premature stoppage of development, that is where the conceptus or embryo or fetus can stop developing, and there can be, in that case, fetal demise. Doesn't necessarily mean that the woman is going to go into labor or have an expulsion of one of those stages of development. In that case, there needs to be surgery intervention. Okay. However, if there's expulsion, that means the woman's body gets rid of the conceptus, embryo, or fetus before viability. Okay, about 60 to 75% of all fertilizations will be spontaneously aborted, and that's before the mother even knows that she is pregnant. And so we refer to that as an unreceptive pregnancy. And then 15% of recognized pregnancies will end in a spontaneous abortion. And that's usually during the first 12 weeks of pregnancy. So really that critical time in development. And then most spontaneous abortions will occur during the first 3 weeks of pregnancy. And then if you remember, we talked about human development looking at the formation of a zygote, morula, and then the blastocyst. Only 70% of blastocysts are considered viable, in which implantation will occur. And then of that 70%, only 58% will survive week 1. Of those that survive that second week, about 16% of that will abort in 1 more week. And about 50 to 60% of early spontaneous abortions have obvious chromosomal abnormalities that cause that spontaneous abortion. So typically that's what leads to early spontaneous abortions. Okay, so we're going to look at the critical periods of human development. Handout figure 548 from zygote to viable. That is this next page in the figure, the next page in the handout. Okay, so to orient you, what we are looking at, here pregnancy is considered from 1 week to 38 weeks instead of 40 weeks, because here we're looking at when actual fertilization occurs. Okay, so 1 to 2 weeks here. I will mention that at this stage of development, there's no susceptibility to teratogenesis. Okay, 3 weeks to 8 weeks is considered the embryonic period, in which you have major congenital abnormalities that can occur. And then during the fetal period, which is 9 weeks to 38 weeks, that's where you have development of functional defects and minor anomalies. Okay, in those first 2 weeks, that can lead to death of the embryo or spontaneous abortion, which is common. Okay, so again, to look at that development, here we're looking at right after fertilization, we have the dividing zygote, development of the morula. Remember, that's about a solid ball of about 30 cells. And then here we're looking at the blastocyst with beginnings of implantation, and then formation of the embryonic disc. And here again, we're looking at the embryonic disc, development of the embryo. Okay, so during embryonic development, if you notice throughout pregnancy, there is critical development of the nervous system. Here you can see common sites of actions of teratogens here with the black dots. That indicates where they commonly occur. But you can have neural tube defects, which are birth defects of the brain, spine, or spinal cord. Really, the highly sensitive period is from 3 weeks all the way to the end of the 16 weeks. And then a less sensitive period would be 32 weeks to 38 weeks. Okay, so in this, for the highly sensitive period, that would be the period during high development for whatever type of tissue you're looking at. So for the heart, really that's from 3 weeks, 3.5 weeks, to a little over 6.5 weeks. That's critical development of the heart. And so if there are issues that arise during that period, that highly sensitive period, there can be that can lead to disorders of development. Less critical period, about 6.5 weeks to the end of the embryonic period. Okay, so with the upper limb, here you can see really the critical period, the less critical period for development can lead to amelia, which is complete absence of the limb, or meromelia, which is only partial absence of the limb. And that can also occur with the lower limb. Then for upper lip development, critical period is from the beginning of 5 weeks to about the end of 6 weeks. Okay, and during that critical period, if there's some disorder of development, that can lead to development of a cleft lip in which the lip doesn't completely fuse. Okay, also here we're looking at development of the ear, those critical periods, development of the eyes, development of the teeth. I do want to point out the development of the palate, in which cleft palate can occur, and that's the tissue that makes up the front of the roof of the mouth, and it doesn't completely join together during development. Okay, so we're going to look at anatomical abnormalities. We're specifically going to focus on cleft lip and palate. And we'll take a look at that handout. And then also spina bifida and neural tube defects. We'll take a look at that handout too. Okay. So looking first at cleft lip and cleft palate, normally in development, the skin will, from the face, the tissue of the face, and then also the palate, will basically start from outwards laterally and grow inwards medially and eventually fuse. Okay, so this would be normal development where you have fusion of that tissue. Abnormality in development if you have if that skin doesn't fuse, like in a cleft palate, that tissue doesn't fuse, or bilateral cleft lip and palate. Okay, so cleft lips actually affects roughly 1 birth in 1,000, whereas cleft palate is about half as common as a cleft lip. Okay, so a cleft palate is where you have a split extending into the orbit, the eye, or location of the eye, and then the palate is referred to as a cleft palate. With the cleft lip, that is, results where there's not fusion of the overlying skin. Okay. Then looking at the development of spina bifida or neural tube defect. With spina bifida, it results where part of the part of the vertebra does not completely fuse. We'll learn about the vertebral lamina later on when we go over the skeletal system. Also, the neural arch is incomplete, and so that leads to the meninges bulging outwards beneath the skin of the back. And really, the extent of the abnormality determines the severity of the defect. Okay, so this is kind of a representation on what happens where you have the meninges bulge outwards. And then with the neural tube defect, it is a condition that is secondary to developmental error in the formation of the spinal cord. Okay, so normally you have a hollow tube that forms, and instead of that occurring, a portion of the spinal cord develops as a broad plate. Okay, and this is often associated with spina bifida. Okay, next we are going to go over bodily rhythms. Chronophysiology is in reference to time physiology. Chrono meaning time on that prefix. Okay, so I have a diagram that I want you to draw here for time physiology. And I will pull that up. Okay, so here we're looking at time physiology, bodily rhythms. Basically, we're looking at a fluctuation, a cyclic fluctuation of some type of chemical or some type of behavior, some type of physiological response within the body. Okay, so here we're looking at time, and here we're looking at amount of change. Okay, so you're going to see this typical fluctuation where you're going to have an increase at a particular time of day, and then here you have a peak. Let's say it's some type of chemical like cortisol. So there's going to be a peak in cortisol, and then it's going to decrease over time. And then typically, not always, about 12 hours later, you're going to have a nadir, which is the low point. And here, if you notice, it's fluctuating around this, what's considered this equilibrium position. Okay, and then here we can look at the amount of change from that equilibrium period. Here we'll be looking at the amplitude, and the amplitude here is usually by the same amount. Okay, so if we want to determine what the frequency is considered one period, which would start from the beginning of the cycle all the way to the end of the cycle, and this would repeat beginning of the cycle, end of the cycle. Okay, so there's going to be a repeat in this fluctuation depending on whatever period of time that we're looking at. Here I was kind of referring to circadian rhythm previously. Okay, so frequency is one period per unit of time. The unit of time that we're looking at is one complete cycle. So frequency is one period per unit of time, or number of complete cycles per unit of time. Excuse me. Okay, so I'll let you finish copying that if you're still working on that. Okay, so we talked about frequency. We're going to look at the different types by frequency. And the first type that you're probably familiar with is circadian rhythm. Okay, so circa means about, DN means day. So it's about a day, which is 24 hours in length. So an example on that would be the adult sleep-wake cycle. It occurs over a 24-hour period. Another example would be the production of certain hormones. One example on that would be like cortisol or melatonin, which is really important in the sleep-wake cycle. Okay, and I have a figure I want to pull up that y'all don't have, which you're not required to have it, but I just kind of want to show you that so you can get an idea on kind of the interplay between some of these hormones or characteristics of time physiology. Okay, so here that represents 6 a.m. to noon to 6 p.m. This would be midnight, starting over again at 6 a.m., noon, 6 p.m., midnight. Okay, so we're going to look at attention span. Decreases throughout the day. It kind of reaches a high point in most individuals at about 12 p.m. or there just after, and then it begins to drop and reaches its nadir early in the morning, okay, in the middle of the night. And then it increases. And if you notice, with our complete cycles, it cycles through 24 hours, okay? Also, we're going to look at melatonin level. Melatonin is very important in sleep and helping with sleep induction. Okay, so if you notice during the day, it's at its nadir, okay, and its fluctuation looks a little bit different in terms of it. Instead of it reaching a low point and then increasing from there, you have a low point over a period of time. In this case, it would be during daytime. It's at its lowest, so that it's not helping to induce sleep. And then it begins to creep up during the evening hours, starting about 7 p.m. or 8 p.m., and it's going to increase over the night period, okay? So looking at the interplay, you notice that attention level is at its highest when melatonin is at its lowest, okay? And then when melatonin is at its highest, your attention span is at its lowest. Okay, also, if you're curious, here we're looking at fluctuations in cortisol, which we'll talk about later, and then also fluctuations in body temperature. Okay, next we're going to look at ultradian. And for this, you want to think excessive. That would be less than 24 hours. So a couple of examples on that would be urination. So urination will happen multiple times during the day, or at least should, if you're staying hydrated. And then also this infant sleep-wake cycle, I have 60 minutes, really, and that's at the initial stages after birth. The frequency can be as quick as 60 minutes, but typically about 2 hours. Okay, so awake for 2 hours, asleep for 2 hours. Awake for 2 hours, asleep for 2 hours. Some other examples in the body, of course, would be blood circulation starting from one point and ending at the same point during a period of time. That time obviously would be less than 24 hours. Also certain growth hormones, and then kind of going along with urination, some individuals will have bowel activity that is ultradian. Or bowel movement in that case. Bowel activity happens throughout the day, and looking at cyclic changes there, it would be considered ultradian. Okay, and then supradian. Think above a day or more than a day. would be more than 24 hours. It could be weekly, it could be monthly, or it could be seasonally. And an example on that would be the menstrual cycle. Another example, if you're curious, would be seasonal affective disorder. It has a circadian rhythm to it. And then free running versus entrained cycles. Actually, we will stop here because we're not going to have time to cover that now. Okay, I don't want to run over time, so we'll go ahead and this is actually a good stopping place. Okay, I hope you enjoy your weekend coming up and that you have a good Labor Day. I will hopefully see you on Tuesday, and if something happens beyond that, with the whole COVID situation, I will, of course, let you know ahead of time. Okay? Thank you so much.